Well, good morning to all of you. For those of you who don't know me, I'm Dr. Britt Nicholson, and I'm the Senior Vice President for Development here at MGH. And it's hard to believe, but this is the 12th in our series that we've dubbed Answering the Call. This is a series of webinars that started shortly after the onset of the pandemic in March of 2020. And this series is, the sole goal of the series has been to address a wide range of issues having to do with the pandemic. And it looks like, thank goodness, that we're beginning to put this in the rear view mirror. There's still more vaccinations to be done. There's still precautions that need to be taken, but the numbers are really truly encouraging. But the session today will highlight travel medicine and safety, summer plans, and future of testing in the communities. Just to remind the audience, no microphone or video capabilities are needed to participate. And at any point during the webinar, you're able to ask questions, and you can do it anonymously, if you prefer, through our Q&A feature. The webinar will be recorded, and a shareable link will be provided after the event. So we're very fortunate to have the panel that we have today. And I'm just going to give a brief introduction of the three panel members so as to give them as much time as possible for their comments. The first is Dr. Gina Rae Kruse, who's a physician as well as having her master's in public health. She's a member of the Division of Internal Medicine here at Mass General and an assistant professor of medicine at Harvard Medical School. Our second panelist is Dr. Sandra Nelson, who is Associate Clinical Director of our Division of Infectious Disease. And that particular division has really carried an enormous load throughout the pandemic. And Sandra is an assistant professor also at Harvard Medical School. And our third panelist is Elise Wulff, who has her master's in education and serves as the senior program manager for Child, Parent, and Aspire Works services. And so with that, I'm going to hand the microphone over to Dr. Kruse.
Thanks, Brett. Okay. It's a pleasure to be here today. Thanks for the invitation to join and talk about some of what we've been doing. I'm going to talk a little bit about the future of testing, but I'm going to start with just a little reminder about how we got here, future of testing in communities specifically. Early on in the pandemic, we learned that not all communities were affected equally by COVID. Communities with high poverty rates, high population density, communities with high proportions of essential workers were at high risk, but some of the recommendations for preventing and mitigating the spread of disease were often not possible or challenging in these communities. Things like recommendations to work from home or to isolate in a separate room in the home. We also learned early on that Black and Latinx and other communities of color were disproportionately represented in our COVID infection and mortality statistics. And all of these inequities really highlighted, all of these inequitable disease patterns really highlighted the need to be able to tailor the public health response to the circumstances in which people live and work. And that kind of grounding in people's lived experience, the grounding in what's going on in the communities and what people are challenged with in these during this pandemic have guided some of what we've done to get more testing out into the communities. So I'm lucky to be part of a team that a partnership between the Massachusetts League of Community Health Centers and community health centers across the state, our Harvard Chan School of Public Health and the MGH Kraft Center for Community Health. That team together normally works on things like cancer prevention and control, but in the setting of the pandemic, there was an opportunity to apply for funding from NIH under something called the RADx-UP initiative. RADx-UP stands for Rapid Acceleration of Diagnostics in Underserved Populations. And so we proposed to leverage our team and our partnership to expand testing and accelerate testing access for the communities that were highly and disproportionately affected. So for RADXUP, we partnered with 5 federally qualified health centers, plus our MGH community health centers came together as a partnership. So we had 6 community health center partnerships working with us on RADXUP. And the approach we took was really to send some resources and to help develop an infrastructure connecting the community health centers who are already at the front line of pandemic response with their community partners to get that window into the circumstances on the ground and where the barriers continued in this evolving pandemic. And so what that looked like was, besides sharing resources to be able to expand testing services, we also worked with the health centers to conduct needs assessments, talking with the community health centers, talking with their community partners, and talking with community residents to understand what the barriers were way back as the project started. But then also recognizing those needs were changing so quickly that we needed to have a window and a line of communication that we asked all those community health centers to convene local community advisory groups with representatives from populations that were that faced barriers or were at high risk for COVID. And so at the MGH partnership, our 4 community health centers came together. So Charlestown, Chelsea, Revere, and Everett. And at the time that RADX was getting going, those community health centers had already done so much in the bricks and mortar facilities to be able to offer testing at the health center itself. The RADXUP team has decided that the best approach would be a mobile approach. And so the RADXUP team created a testing van. And there are a few things that came together to make that possible. So one, besides the RADXUP award itself, the organization was partnering with a local transport company. And as part of that relationship, we got a van and a dedicated driver and created a testing van. The next part of that was working on those community partnerships to figure out where this van was needed. And so through the local community advisory group and building on the rich relationships that the community health centers that MGH's community health centers already have with their communities, working with the local governments, working with community-based organizations and the local boards of health, we reached out to those connections to say, we have this service, where is it needed, how should we do it? And the van got going. And so the van was set up in partnership with community-based organizations linked with other services, like say they were doing food distribution, we could have the testing van there. We worked with the cities where you could see within this community, testing was here and here, but this community is still challenged to access testing. And so let's bring the van over there to serve that population who may have transportation barriers to accessing the other testing sites. And so the van was out there, really getting out there on the ground to try and overcome some of the barriers that we were hearing about from community partners. And in addition to just geographically putting it in an accessible place, but also putting it together with trusted partners, having extended hours, evening and weekend testing sessions to be able to overcome some of the barriers people were facing. The van was also able to offer testing for free, so insurance and costs weren't a barrier. And the van was walk-up testing, so having to schedule appointments also didn't create a barrier for people. So trying to really take what we were hearing from the community and trying to address things, those barriers as best we could. And the neat thing about having the advisory group and those open lines of communication is, as the needs and the barriers evolved, the testing services could evolve. And a couple of examples of that are, we heard from our local advisory group that people wanted faster test results. The van was set up with PCR-based testing and telephone resulting initially, but in hearing that, our amazing team, on our team, we have some members of the the Division of Infectious Diseases in Sandy's division who helped us to get set up with rapid testing that we could, in a parallel workflow on the van, so the van could continue to offer PCR testing that many people needed for documentation, for work and school, but also offer rapid testing so people could get that result in 15 minutes to inform their decisions, like whether they should go and see family or not. And so having that kind of communication and just an amazing team to try and address and respond to that has really been what RADXUP has been all about. And I think the other thing I wanted to highlight is as that testing van was getting out there and we were working with the community partners to figure out where it should go, we also leaned on them a lot to get the communications out in terms of where the van was going. And so we tried to, we worked with those community partners to have a very targeted outreach strategy to advertise the van services within the community. And more than over the course of the van so far, more than 90% of the van testing participants are from either live or work in the 4 communities that the MGH Community Health Centers serve in Chelsea, Charlestown, Revere, and Everett. So we felt like that was a great demonstration of that really targeted outreach and close connection with the communities to get testing to those communities where it was needed. And then I think I'm just going to wrap up with the one final point about having this infrastructure set up to work with these community partners. Right now, vaccination is really at the forefront of everybody's mind in vaccine distribution. And so having that kind of living connection, we've been able to adapt and grow services even as vaccine rollout is happening, both to think about, well, what is the message about testing now that the vaccine is getting out there and more people are getting fully vaccinated who still needs to test. So helping to work with the communities in terms of like what the messaging is. And then also the van's been lucky to be able to pair some pop-up vaccine sessions together with its walk-up testing sessions. So working with those community partners to figure where we could have some walk-up, pop-up vaccination. So with that, that's sort of in essence this community-based approach, really having this relationships with this community, trying to have an ear to the ground about what the needs are in the local community, and having a system that can adapt and grow as the pandemic continues. And with that, I'm going to hand over the mic to Sandy.
Thank you so much, Britt and Gina. I think before my comments, I'd like to start by just reflecting a minute on this role. I've spent a lot of the last year, as Britt mentioned, counseling and advising people on what they can't do. And I will say it's a tremendous joy to be a little bit more forward thinking about what we can do, what's not forbidden anymore, but how we can begin to grow into this next stage of this pandemic. So I was asked to speak about summer travel safety. And I think in order to do that, I'd really like to provide a little bit of a background on what we have learned about vaccination since the vaccines have been rolled out. One of the things that we know from the early clinical efficacy studies, and these have been corroborated by many large real-world studies that we call effectiveness studies, are that the vaccines are highly effective at preventing symptomatic infection, as well as severe infection and death, hospitalization and death, upwards of 90% for both of the mRNA vaccines, and just behind that for the J&J vaccine. But what hadn't been known prior to the rollout was whether or not the vaccines would also protect against asymptomatic infection and protect against transmission. And the reason that became an important question is because we know that some individuals who never develop symptoms yet still have circulating virus, and that virus can be passed from one person to another. So this was one of the most urgent questions that arose after the vaccines were rolled out. Now, what we have learned from some of these real-world effectiveness studies are that asymptomatic transmission is blocked at a fairly high rate by all of the vaccine studies. These are studies that are done in individuals who are vaccinated, and then for one reason or another, either through the context of a clinical trial or through the context of their workplace employment, are being screened with tests even when they're not having symptoms. And what we've learned from these tests is the vaccines are around 80 to 90% effective, some studies a little bit lower, at blocking asymptomatic infection as well. And so what that means is that those people who have been vaccinated are significantly less likely both to have symptomatic infection, but also to be walking around with asymptomatic infection. When we think about transmission, clearly, the most important way of understanding that transmission is blocked through vaccination is by blocking infection. So the fewer people that are infected, whether they're infected with symptoms or infected in the absence of symptoms, the fewer people that are infected, the more likely that the vaccines will be blocking transmission. But we do know that the vaccines do have a small rate of failure, that some individuals, particularly those that have weaker immune systems or in the setting of high density exposures, will still develop COVID-19 infection, symptomatic or asymptomatic, and they still may be able to pass that on. And that's been one of the big unknowns since the vaccines were rolled out. Several studies have informed this risk as well. One of the types of studies are what we call viral load studies. So the viral load is the amount of virus that is detected in the tests that are done, the tests that Gina was mentioning. We can actually measure a quantity of virus. And we know that the more virus you carry, the greater the risk that you will transmit infection. And so one of the studies that have been done early is looking at what the viral load is amongst individuals who test positive after vaccination. And several studies have now demonstrated that individuals who are vaccinated but test positive are carrying less virus. And from that, we can infer that they're less likely to transmit. The other piece, and there's only one study that I'm aware of that has looked at the actual transmission risk of people who have become infected despite vaccination. And if you look at the household exposures of those individuals who have been infected, you can calculate what we call an attack rate, the proportion of contacts who become infected from an individual who's carrying the virus. And what we've learned from this single study is that individuals who are infected but vaccinated, that their contacts are about half as likely to develop infection than those who are unvaccinated and infected. So if we take it all together, the likelihood of transmission from individuals who are vaccinated is very much lower than those who are vaccinated. And that's because they're less likely to get infected. They're less likely to have asymptomatic infection. And when they do have asymptomatic infection, they have lower loads and are lower viral loads and are less likely to transmit. I'm going to turn briefly to masking. I was asked to speak briefly around mitigation measures. I don't want to spend a lot of time on this because I think we all understand that masking is one of the most effective ways that we can block transmission in the absence of vaccination. And I think the current guidance around masking is such that if you're vaccinated, in most settings, masking is no longer necessary. The exceptions to this are if you are in an area that is either higher risk because there are vulnerable individuals or higher risk because of crowd density. And that would be true in healthcare settings, in prisons and congregate care facilities, for example. Masking is still really recommended in those settings. Most settings outdoors, whether vaccinated or unvaccinated, masking is unnecessary. We have learned that the likelihood of outdoor transmission is very low. The exception to this would be in crowded settings, such as a baseball game at Fenway Park, for example. The need to mask also depends upon the individual's responsiveness to a vaccine. And one of the caveats that I didn't mention around what we've learned around vaccines is that those individuals who have a weaker immune response are much less likely to respond to the vaccines. We don't entirely know why this is, whether it's decreased antibody levels or other elements of the immune response, but we do know that they're less well protected than individuals who have a healthy immune system. So individuals who have a weaker immune system, and particularly true for those who have had organ transplants or are taking medications that affect part of their immune system, they should still consider themselves effectively unprotected and continue to mask as they did before. And then, of course, the other piece that impacts the decision to mask is around community risk. And right now we are in a place in Massachusetts where the rates of disease are very low. So the chance that we're going to individually encounter the disease is quite a bit lower. But if that changes, mask guidance may also need to change. Now, moving on to travel, I will admit that guidance around travel has been confusing. And the reason for that is travel is really the reason that we have a pandemic. The virus hitchhikes on the human host to reach a new destination and then to begin to establish a new infection cycle. The decisions that we make around travel not only have individual impact, but they can also therefore impact our families and our communities. When we make a decision to travel, I think we have to think about it both from an individual standpoint as well as from a public health standpoint. And from an individual level, there are really multiple considerations when we're trying to decide if it's safe to travel. And one is, what is the risk of the travel itself, the air travel, the cruise ship, for example? Another is, what is the risk in the destination? How much disease is there? How rapidly is it spreading? Are there variants that are circulating that could put me at risk? And what activities do I plan, and would that put me at risk? Regulations have become one of the more important elements. Some destinations are requiring pre-travel testing, post-travel testing, and quarantine. And so understanding what the regulatory climate looks like, both in the destination and then as well in the United States, is important. And right now, all returners from international travel need to have a test prior to boarding any international flight to the United States. So these become cumbersome and add a little bit of complexity to the decisions around travel. Also, we need to think about what the risk is to individuals in our community upon our return. Do we live with individuals who are higher risk for infection, or do we work with them? And how would that impact their risk if we became infected? And then I think there's also the logistic risk. If you were to test positive in another country, what does that mean? You wouldn't be able to board a plane to come home to the United States. There are individuals who've been stuck on cruise ships, as you know, for many weeks at a time because they haven't been able to find a destination willing to accept them. I apologize for this background noise. I'm almost done. I think from the standpoint of international travel, there are guidelines that are available. These are rapidly evolving. These are available on the CDC's website as well as the State Department in terms of travel guidance. And I think it's important to understand that this is very fluid and that this is an area that may continue to change. So as travel approaches, I would encourage people to look at this guidance to see what has changed. The CDC has characterized each destination with a certain level of risk, depending on the amount of disease that is circulating and depending on the trajectory of those case rates, as well as the presence of variants. And some destinations, some countries, around 60 currently, are designated very high risk and individuals should not travel to those destinations. Other countries are designated to be acceptable levels of risk for those people who are vaccinated, but some really only if that travel is considered necessary. So all of that information is available on the CDC website, and I look forward to taking your questions. I'll go ahead and hand off the microphone to Elise.
Great. Thank you, Sandy, and thank you, Gina. It's a pleasure to be here, and I want to echo what Sandy was just saying, that I'll pick up the baton with what can you do as things are starting to become our in-person reality this summer. So the first thing I'm going to talk about is specific to the summer camp scenario, and what, as a parent or a caregiver or someone who spends time around kids, what can you expect to encounter in the summer camp scenario? So the body of literature that I'm using to share these recommendations is the American Camp Association. Not all camps are accredited by the American Camp Association. However, if your child's camp, or if the environment in which your child is participating this summer, like Hale Reservation or other public facilities, is accredited by ACA, then the standards that I am going to discuss very briefly here are something that you can expect in your environment. There is also a distinction between a day camp and an overnight camp. In some ways, an overnight camp is I hesitate to say this word, but a simpler situation, in the sense that once everyone arrives, you can go through a screening process and then you close the site. So I'm going to spend a little more time talking about the day camp scenario. A resource I want to share with you is, if you go to the American Camp Association website, they actually have a COVID resources for parents section of the website that I highly suggest. It's very user-friendly. It's also great if you have teens or young adults, to give them an opportunity to read this material themselves. They update it very, very regularly, and I think and they will also link back to the CDC. So I appreciate the chaining of information there, and that it's a really reliable source. So what I want to share a little bit is the American Camp Association is basing their guidelines on the limited but solid research we have from this past year in public schools, because it's the most analogous scenario, where you have children and staff intermixing, where they're sharing materials, they're inside and they're outside. So that's the data that they're using, as well as some private consultation from public health groups. So some of the recommendations that you'll see this summer, of course, the strong encouragement that everyone who is able to receive a vaccine, staff, adults that are on site, as well as children over the age of 12, receive a vaccine. Every camp that is accredited by the ACA has the expectation to create clear plans, protocols, and policies. So I think it's important that if this is an area of concern for you, or as you would with any program after the year that we've had, please reach out to your camp and ask them to see a copy of these policies if they're not proactively a part of your orientation packet. A couple of things your children could expect this summer, and this is the umbrella that I'm going to talk about this is under a site where there are both vaccinated and unvaccinated individuals sharing space and sharing materials. So when inside, masks and 3 feet of social distancing. Masks are not required outside. No masks for water activities for reasons of sheer safety. So because of that, water activities are going to look very different this summer. Without the ability to wear masks, which is certainly the priority just in terms of safety and respiratory systems, that requires that during water activities such as boating or playing in a sprinkler or going swimming require the 6 feet of social distancing, if not further. So that's going to lead to another trend which your child may experience this summer, which is a modification in the curriculum, the schedule, the daily activities. If your child has attended this camp in the past, an important conversation we're going to talk about in a minute is how to help them understand what may be different, what may be the same, and what may be similar. And that's an important distinction, but more on that in a bit. Another thing that your child will encounter is there will be pods that have a stricter, that are not able to mingle with other pods. So in most typical summer camp settings, you kind of have your camp group, and then you might intermingle more with camp groups of your age range, and then you might have all camp talent shows. And this kind of concentric circles of contact get a little larger. Those are going to be very strict boundaries this summer. Your child's pod will be their pod. So that has an impact on curriculum. You're not going to see whole camp activities. You're not going to see an intermingling of camp groups. And that's also true for camp staff, that camp staff will be assigned a certain set of pods or a single pod, and then will not be able to mix. So again, that will have an impact on your child's schedule, their curriculum, their routines, and the activities they participate in. Two other things that will be a part of your child's reality this summer is the routines of sanitizing and hand washing, which your child is probably already familiar with. And then one that I'm actually not that upset to hear talked about more and more is mental health. This year was kind of the kick in the pants that everybody needed to say, hey, if we're teaching kids, if we're helping them learn arts and crafts, we really just can't learn our discipline anymore. We have to think about kids holistically. We have to have some baseline understanding of social emotional development. And this year expedited that process in camps and schools, getting systems off the ground that support their staff to help their participants and their campers manage their mental health. So of course, no one would have wanted a global pandemic to have to happen for us to be moving in that direction, but it's a strange silver lining that the camps are now offering more training to their staff. Staff are paying better attention to camper indicators of their needs as it comes to anxiety or what might be a bit of a wonky social development after a year of atypical social interaction amongst kids. A couple of other things that's just a reality this summer is camps are likely not allowing outside vendors, which will change your child's schedule, and they are likely not allowing parents or visitors. So prepare yourself for the reality, or at least ask that question up front, and don't be surprised if the response is that you cannot observe or visit your child's program this summer. So again, overnight camps have a little more quote control over the situation in the sense that once everyone is there, they have a much greater restriction around the influence of outside parties. And so overnight camps might be able to experience greater, longer periods of time without masks, with the understanding that they will have extensive screening and pod-based testing protocols up and running. So I'm going to shift a little bit away from the specific context of camp and move more towards things for parents to consider, parents and caregivers, as you're supporting your child, whether it's a young child or an adult child, in the role to transition into this new world. A couple of things to consider to help you best interact with your child's programming site or location, whether this is a camp or a summer school, or even take this recommendation and think about the fall. Have a clear understanding of the program's expectations for your child's participation in the program. Go into the start of the summer having what you need to know about how contact tracing is done, what are the screening protocols, what happens if my child's staff is out for a day. These are all questions you want to ask ahead of time so that we kind of separate this intensity of needing the answer. The last time you want to realize you don't know that answer is 8 a.m. the day you have to send your child to camp, and all of a sudden you're learning their staff's not there. Give yourself permission to have that answer ahead of time. It helps your mental health, which in turn helps your child's, and it helps your ability to have a non-emotional collaboration with your camp program. Secondly, this is a recommendation for the summer and heading back into the school year. Think about your child's and your family's experience of COVID and organize that into a one-pager. I would suggest some categories like, during COVID, my child's best day looked like this, the worst day looked like this, and an average day looked like this. Our family experienced X, Y, and Z. I was working from home, my husband was here, so childcare was somewhere in the middle. One pager is the real operative term here. We're only going to read it if it's one page. But distill this incredible amount of amorphous COVID experience information that's floating in your caregiver head and take time to think about it and organize it into a one-pager that you can then be empowered to hand off to the environment caring for your child to help them understand what this last year has been like for you. Context, context, context. A couple of other recommendations, things for parents and caregivers to think about: your child's ability to wear a mask and your child's understanding of what COVID meant. This is an important section in this one-pager. My child understands that COVID meant this. Otherwise, you worry a little bit about what are they going to hear, and is that going to not enhance their understanding, but enhance their confusion? Preview and practice a couple of scenarios we know your child will run into, like hot weather with a mask. Help your child practice the language they might want to use to tell a staff member, hey, I'm getting really hot in this mask. Normalize that there will be problem solving this summer. None of us have this all figured out, and we're just trying to take different scenarios as they come our way. So the core practice and preview that you want to give your child is thinking about, how do you think about what's happening for you? And how do you organize language to tell it to other people so you can best have your needs met? And the last thing I'll touch on briefly is the transition back to the school year. My program Aspire will be offering some after-school social groups and weekend social groups. So we're trying to recognize there was a tremendous amount of learning loss that happened this year, not just in academics, but in social emotional development. So your child, whether or not they carry a formal diagnosis, it might be something to think about enrolling them in after-school social groups so that you can get a professional set of eyes on them and think about, where are they in this atypical within the atypical, or typical within the atypical. Structure, structure, structure. Structure binds anxiety in kids. You don't want to over preview if you don't know the answer, but you also don't want to present as not knowing anything. And then lastly, remember that the context that's come out of this is putting an extra emphasis on making sure that kids' holistic needs are being met. Their emotional regulation, their ability to communicate socially, their ability to start learning what messaging happens when you can see this part of someone's face. So if your child doesn't carry a diagnosis, it's still always an option for you to reach out to your child's providers or see the resources in your area about having someone give you some feedback about how you can help your child in their social and emotional development after what was a very interesting year for the rest of us. So with that, I'm going to turn it back over to Britt to get to some wonderful Q&A, and I'm looking forward to answering those questions. Thanks for your time.
Elise, thanks very much. And as usual, the questions are rolling in. Sandy, I'm going to send the first one to you. The audience says, I'm 66 years old. I had the Pfizer vaccine, had absolutely no reaction to it. Is there a test that I should get to see whether I've had an adequate response?
That is a great question, and that is really something that we are asked on a frequent basis. First of all, we hear a lot about these difficult side effects to the vaccines, but in fact, the difficult side effects are more common in people who are younger. So somebody who is 66 and had no symptoms is actually quite typical. We don't expect a lot of symptoms for our older adults who are getting the vaccine, those over the age of 60. Having said that, there's no correlation between the symptoms that people have have with vaccinations and the level of immunity. So just because one didn't have symptoms does not mean that one is not immune. Now, the challenge is, while there are tests that can be done in a research setting, there is currently no test of immunity to the vaccine. We know that some people, most people who respond, do so by having an antibody response, a measurable antibody response. But we don't actually know what that means in terms of correlate of protection. So a positive antibody test doesn't necessarily mean you will be fully protected, nor does a negative antibody response absolutely mean you won't. So right now, all of our current guidance is there is no need for testing after the vaccine. We can infer that individuals who have been vaccinated are immune, provided they don't have one of these conditions that weakens the immune system.
Great, thanks. And Gina, the next one's for you. What experience and learnings from the RADx program might impact or inform healthcare delivery beyond COVID and in the future?
Thanks for that question. I think my response to that would really sort of build on, I think early on, as I gave that kind of brief reminder of where we started, thinking back to some of the barriers people were facing to be able to employ the mitigation strategies that were being recommended, they had a lot more to do with sort of social circumstances and context than what was available in the clinic. And so bringing those social, health-related social needs and social context into the healthcare conversation, I think the pandemic kind of highlighted that across the board. And I think in our RADx Up project, we were really able to try and work to address some of those barriers to get more testing out to populations. But I think that relationship with the community to try and tackle some of those health-related social needs is going to, I think that's sort of been brought to the forefront and going to continue to be some of the tools that we've learned, not just with RADx, but elsewhere in the healthcare system about working with those kind of psychosocial context issues as healthcare providers, I think is going to continue to be really relevant and only make us more effective at promoting population health.
Great. So Sandy, back to you, and I'm sure you get this one on a regular basis too. What is going on with toddlers in COVID vaccine?
This is a good question. I will just provide a preface that I'm not a pediatrician, but it is something that we think about a lot. And I think that, we all understand that the vaccines have been tested first in adults and then are sequentially tested in younger and younger children. It does require for the younger children, because their immune systems respond a little bit differently, it does respond for the youngest children. We have to do some dose finding studies that were not done for the older children. So it will take us a little bit longer to get through those studies for the toddler ages. The vaccine manufacturers, in particular Pfizer, is the one that is most advanced in its studies of younger children, are expected to release some preliminary information in about September. Prior to that, we have no data. I think, the questions are really around, right now, we don't actually know that it's going to be necessary to vaccinate young children. We know that they are less likely to get very sick, and we know that they are less likely to transmit infection. That has been proven to be a pretty consistent finding in many of these studies. And we think that so far with vaccination of adults only, we're seeing dramatic drops in cases among kids. This is seen in Israel as well. So it's not as clear to me right now that vaccines for younger children are going to be necessary as much as they have been for older children and adults. But that, I think, remains to be seen. And there's still a lot of balls in the air around things like the variants and others that may affect some of these questions in the future.
Great, thank you. So Elise, this question comes in. It says, first of all, I apologize for what might seem the rambling nature of this question, but when I get through, I think you'll understand. I have an 11-year-old son who is quite good at hiding his emotions. And with all that's been going on with regards to concerns about the COVID vaccine, the talk about death, the importance of mask wearing, he's scheduled to go off for a sleepover camp this summer. How can I be sure of what things can I do to make sure that he's prepared for camp?
That's a great question. And I wouldn't call that rambling, first of all. So I think a starting point is to recognize and to share, especially if he's 11, to share pretty openly with him what you know, what you don't know, and what you think. So kids tend to default to a binary system of thinking, right? I know this or I don't know this. And they'll often come to their parents and say, but what's the answer? And what's been highlighted over the last year is the importance of helping kids build a healthy category for ambiguity. So what I would say is to do some processing with your child, especially whether or not he's been to this camp, about what might be the same as something he's experienced in the past, what might be similar to something he's experienced in the past, and then what might be different. So this can give kids a framework to sort their concerns. Same means you have a pretty good understanding of what's going to happen. You should be able to predict, and we can do some preview and planning. Similar means you can probably use data of experiences you've had in the past to feel competent going into this situation. And then different would then be the category that we do want to have conversations. And this is where we help kids kind of tease out what's the category that actually warrants some anxiety. This is a good technique for adults too, right? So then I'll share one more strategy just about this different category. So the goal is not to help him not be anxious. And that's a hard thing to hear, right? But the goal is not to release kids from the expectation of experiencing anxiety. The goal is actually to lean into it and normalize it, and to help them build tools to figure out what to do with their anxiety. If kids feel like they shouldn't be anxious, then they get into this snowball effect of I feel anxiety, and because I feel anxious, I should feel more anxious. And they become overly reliant on adults and caregivers to answer their questions. So what this might sound like for your child is when they have a question, say, that's such a great question. I don't know the answer, but I can help you figure out how to get the answer. So then you want to take a more executive functioning approach and say things like, who would you ask? Who could we ask? What answer might help you feel better? Now, this can get kind of obnoxious if you're working with a teenager, because they're probably just going to say something like, never mind, forget I asked. So put your own parenting hat on and figure out how far you can go with this tool. But the big take homes are you want to help them build a sense of what does anxiety feel like in my body, and figure out how do they express that and get their needs met, as opposed to you being the source of their comfort.
Thanks very much. Gina, this one's back to you. The questioner says, I am so impressed with your description of the RADx program, but one question I have is, how did you go about getting community input to these programs so that you felt comfortable that you were really addressing the needs as seen through the eyes of the community?
Thanks for that question. I think that answer really has to recognize what we were building from a place where the community health centers were already at the forefront of the pandemic. They already had rich connections within their communities. And RADx Up just gave us the opportunity to send a few more resources to be able to enrich those relationships. So, the community health centers already had programs that they were doing pre-pandemic times with some of these community-based organizations for food insecurity or housing or educational resources. And RADx Up gave us the space to say, let's bring that group together and have a conversation where we can, have a little bit of people's time to be able to talk about really specifically what are the testing needs and how is it evolving. And, and I think one of the, especially given the rapidly changing context, having that space to have that conversation, it wasn't like a one-off conversation. It was one you had to continue, and we are still having to continue over time to figure out how things are changing. The testing recommendations change. So I think, it just, I think, highlights the importance of, as we're, for folks who want to work in community-based work, it takes some resources and investment. These are valuable relationships. They help us do a lot that we couldn't otherwise, but it takes time and effort and resources to make sure that that communication and that connection is there. So yeah, thanks for the question. I think it's just that having the space to build on what was there and to focus some of the conversation on where the testing needs were among the other needs of the pandemic.
Great. So Sandy, I'm going back to you here. It said, Dr. Nelson, in your comments, you did address the fact that those patients who are immunosuppressed or immunocompromised might not achieve a sufficient level or any level of protection from the vaccine. What should those individuals assume once they've been vaccinated? Should they assume that they have no protection? Should they assume that they'll may have some protection but should continue to wear a mask? What would you say to them?
So I think, you know, in some sense, this is going to depend on the individual circumstance. And some individuals who are only mildly immunosuppressed may actually have full protection from the vaccine. I think one of the challenges right now is that people really want to know. And we're seeing a lot of people who are asking for tests to understand if they're protected or not, but we simply don't have the tests yet that tell us if they're protected. So we're living in that state of unknown right now. I hope that we will have answers for people reasonably soon around that and be able to offer a test that actually has some meaning attached to it. Right now, the recommendations are to assume that if there is a higher risk setting, closer distance transmission, high congregate activities, that the individual is going to be better off if they're using the same mitigation strategies that they did before they were vaccinated. One of the great advantages, though, is that this whole concept of herd immunity means that the herd protects the individual. And this has always been true of vaccinations, that there are some people whose immune systems are weaker and that they really rely on the people around them to be protected. And as long as those in that inner circle are protected, that's going to, with vaccination, that's also going to serve to protect that individual with a weaker immune system. So I think more to come on that.
Well, thank you. So once again, we've reached the end. It's 11:45. We have a number of questions that have come in. First of all, I'd like to thank our three panelists. You've all done just such a terrific job. And I'd like to thank the audience for the questions that you've asked. It's, I think the way you've asked the questions, the topics you've raised have just helped to serve us, educate us even more. So on behalf of everyone at the MGH, thank you for joining us and continue to be safe out there. Thank you.